Hi, good day, everyone, and welcome to the next session of TIO 2026. This session is on the latest advances of procedural imaging. I'm Azeem Latib from New York, and I'm delighted to be joined by this esteemed panel who I know I'm going to be learning from in this session. So we have Nadira Hamid from Minneapolis. Hey, Nadira. Edwin Hull from New York, Arif Khokhar, and David Hildick-Smith. In this session, we're really going to start focusing on imaging. As you know, for structural interventions, imaging is really the basis of how we do everything. The images, our partners, we blind without them, and so I think it's important we spend some time, looking at really how imaging has progressed. I sometimes think it hasn't progressed as quickly as the devices. The devices have sometimes progressed quicker than the imaging, but thanks to the dedication, expertise of people on our panel, we're going to delve into a little bit some of the techniques and really give you an update on how the whole area of imaging has progressed to today. So, Nadira, without further ado, we're going to start with you, and I think you're going to share. As those who don't know, Nadira is really a worldwide expert on structural heart and structural heart imaging. And certainly one of the areas where she's really focused a lot of her research is tricuspid interventions. And, with now devices approved globally, Nadira, TEE for transcatheter tricuspid interventions is becoming even more important.
Yes, thank you very much, Azim, for the wonderful introduction. And thank you so much for including me and to the Transcatheter Intervention Online. And it's truly an honor and really humbled. Tricuspid intervention, Azim and everybody on the panel has really humbled me as a structural imager. And here are my disclosures. And I've learned a lot in the last few years as a tricuspid intervention has really started off and down to the basics of tricuspid TE imaging. What are the key views? And as you know, we love our RV inflow outflow view. And here you can see no Doppler on top, and the bottom is the color Doppler. And as we sweep across the RV inflow outflow, is similar to your mitral bicommissurals, and really appreciating where that jet is, the length of the septal leaflet, and whether it's suitable for TIR or replacement technology. But one of my favorite views is the distal esophageal view on the transesophageal echo, really pushing the probe a little deeper as you can see the coronary sinus on the orthogonal side and really beautifully seeing. And we do a lot on the table distal esophageal views for this interventions. You can put a pressure back on your right hand side or on your right shoulder to really elevate the patient off the table to really get this imaging as clear as possible. The other favorite view and key view is your transgastric view on the TEE, and really appreciating and making sure that you're at the leaflet tips. And so I love the primary view at 0 to do the RV inflow outflow as you push the TE probe as deep as possible, and then biplane it as your orthogonal view at 90, and you know that you are really at the leaflet tips. So that's my little trick for the transgastric view to really know that you're at the tips of the leaflets. And then once you're 0 degrees, you can just move forward at 90 degrees or 74 for this patient, put a color, and you know that you're at the leaflet tips. And this patient, you can see the lead right in the postural septal commissures with jet around the lead, and you know this is a CIED related TR. But really down to TE intervention, they're really assessing what are the big five for success. You've probably seen this before, an acronym that I come up with the fellows, and is really looking at the gaps, appreciating the gaps, the anatomy, the length of the leaflets, suitability, the coaptation planes for TIR or replacement technologies, location of the leads, where is it? Is it impingement? Is it interacting the subvalvular apparatus? And appreciating the windows. And I'll show you cases after this where shadowing and the TE windows are just not optimal. That is real life. And what do we do? And 3D eyes, which Edwin will talk about, can really help these cases. And then also appreciating the RV and the left side of heart disease. And the mnemonic for this is the Galileo, which I've used a lot in my pre-screening. And this is also translated, to the GLIDE score, which is the predictors for your TIR therapy. And so the looking at the gaps, the morphology, I'm just putting the slides back. image quality, the coral structure, and the on force as where the jets are star shaped or oval, and really realizing which patients are best suited for which therapy, because ultimately you want to bring down the residual TR down to mild, no longer moderate, down to trace of mild, so that they can not only have that quality of life, but really good outcomes. And so this is a case where I call it the A frame. So this is real life on the table, baseline distal esophageal views. There's a little shadowing, but you can appreciate a lot of the jet is around that lead, as the lead is really to the posterior to anterior. And you can see the transgastric view as well, with the lead centrally and the jet around it. And so really we want to tackle this. The gaps are small. And so we thought the TIO therapy might be suitable for this. And here intraprocedurally using TE guidance, I do a lot of live 3D to guide the delivery system down as my interventionist maneuver to the septum and down into the on force of the tricuspid valve. And then going to 3D MPR on intraprocedural TE, which we use a lot, for trajectory and perpendicularity to the tricuspid valve. You can see the first two images, and on the right hand side as we go down underneath the leaflet. And moving then to the transgastric view, this is really the holy grail as you open up the clip arms and assess right in the anteroseptal. And then we use eyes for this imaging. We park the TE probe in the transgastric because I knew there's a lot of sharing from the lead as well. And your distal esophageal view can also be shadowed as well. So 3D eyes navigation, which Edwin will talk about, you can see using digital steering to help visualize the arms. So you can see the 3D eyes imaging as we grab here, but you look on the right-hand side, the septal leaflet. I'm a little bit dubious about that. But using confirmatory views and your transgastric, you can see with the red arrow that the septal leaflet is not in the middle of the clip. And we use two confirmatory views to really assess the septal leaflet into that clip arms. And so then we optimize the septal leaflet using eyes and also the transgastric view here, as you can see, imaging. And so you can see the transgastric view, the leaflets of the septal leaflet right into the middle of the clip. And on the right hand side, you can see a really good grasp of the septal leaflet. And so we deploy that and putting a second tri-clip XTW using an A-frame technique. And so using 3D eyes, because the A-frame technique you can see with the TE, it can be challenging to visualize it. So here you can see the transgastric view using the A-frame technique and using eyes to acquire the septal leaflets very well. You can see on the right hand side. And so this was done and the TR was substantially reduced. You can see on the right hand side on transgastric view, and quantitation is what we do from baseline and also post procedure as well. So post procedure, of course, we measure the jets in between the clip arms and down from severe down to 18, which is mild tricuspid regurgitation. So really have a good reduction of this patient. And here you can see the final images of these patients. So you best use to TEE with 3D eyes, and combining both of this is what we usually would love to do to really speed up not only the efficiency, but really with dedication, confirmation of the leaflets. And here for replacement technology is something that I'm humble with TE, because this patient, as I walked into a room, has not only 2 leads, but has actually 5 leads. So that you can see from the TE here, really a lot of shadowing. I did all the maneuvers I can, but this is what I get. The transgastric view as well, you can get some images, but 3D MPR, as you know, your 2D is not good. Your 3D MPR from your transgastric or your distal esophageal view will not be optimized. And so for this patient, with 5 leads. So I like this slide because you can see what the Edwards tell me. Look at the bottom left. It's like a spaghetti in their heart where there's so many leads. And unfortunately, this patient was left with an abandoned RV lead and an RA lead, and they had a replacement of those 2 leads and a CS put in. There was no extraction. And so this patient has symptomatic TR and was suitable for the evoke. And so I was very humble and did 3D eyes on this evoke, and you can see the imaging of the ankles on the left hand side. And post deployment, you can see we did the entire case not only with TE but also with ICE as well. And so for the humbling key important points for TEE: understanding with leads the trajectory, not only doing the standardized TR imaging, assessing whether is it a clip or replacement technology, and looking for gaps. And just a couple more slides before I end. So using TE also during your right heart cath to see whether you can manipulate the lead. So here you can see pre-manipulation and post-manipulation to see if it's suitable for a TEER or replacement technology as well. And this case that we had, you can see we are unable to manipulate the lead. You can see it's really stuck into the septal leaflet and the gaps are huge. So no treatable gaps, not ideal for tricuspid T-tier, and so we're thinking of a replacement technology. And so this is an interesting case that I had during the case thinking for TriClip. But on the table, this is what I detected. You can see the right-hand side on 3D, really impingement, and actually on 3D eyes, you can see the leaflet is perforating that septal leaflet because of that lead. And so using all modalities, not only TEE, but you also 3D eyes to help visualize and confirm. So in conclusion, the TE is so useful, really humbled by it, knowing not only the etiology, the TR quantitation, the morphology, looking at trajectory of the leads, what is the leads causing that TR, also appreciating the RV from the mid-esophageal and the distal esophageal, use all modalities, including 3D eyes, thinking, is it a clip candidate, replacement technology, and if not, a heterotopic, and ultimately working together with your EP, heart failure, and surgical colleagues for the best of these patients. Thank you very much.
Nadira, as expected, that was fantastic. Thank you for a great presentation overview. We're running late, so we're not going to take too many questions right now, but I know you need to leave. So let me just check with the panel if any of them had any questions for Nadira before she goes back to her patients. No, looks good. I want to remind the audience as well that we do. Oh, sorry. Go ahead, Edwin.
Oh no, I was just gonna, bring up that was a great overview and talk, of course, as always. When you're training your interventional echo fellows, I guess, how do you start them off? Because I agree with you. Nowadays with tricuspid, I mean, the views and the protocols are almost like very established compared to when we started doing this 10 years ago. But the training can still be a little bit tough for people. So how do you approach that?
Oh, Edwin, that's a great question. I think it's not only a learning process, it's dynamic. And the more they see, the better they do. And so I always love them doing the TR outpatient screening, TEs, because I think that's where you learn so much. The views and optimizing the imaging, the small wheel, and different levels of the esophagus, and learning optimizing that. And they always give me a call as well if they can't get the views, and I'll rush down to help them. But I think increasing their exposure to the complexity of TR studies will really help them. And so when they are in the case, they know how to handle it, they know how to tackle it. It's a work in progress, it's very hard. As we are learning, I'm learning too, still. As we had get some very tough cases, and the more they see, the more they learn, and also going to meetings like this and congresses and workshops to familiar with the software and how to improve their efficiency and workflow. I think it's a work in progress, but as long as we interventional echocardiographers, you, me, and many others stay united and help all these images, I think everybody can do better.
That's great, Nadira. Nadira, I'm going to ask you one question from the audience before I let you go. And the question was, for transcatheter tricuspid interventions, what are the most challenging imaging views to acquire? And how do you optimize quality in patients with poor acoustic windows? Very quickly, maybe if you had any tips and tricks.
Oh, yes. I mentioned during the talk, putting a pressure bag over your right shoulder of the patient as they lie flat, a little elevation can really help improve. And we have cases of such. Um, and tips and tricks using that small wheel a lot, all views. And once you get a good view, try to stick to it. The shadowing can be from multiple things, not only the left sided prosthesis, even the delivery system. And I think using all tools and trying to understand fluoroscopy as well during the procedure can also help you to maneuver where the probe can be. Transgastric view, I think Edwin can also attest to it, is one of the underestimated views for these procedures, because once you get a good transgastric view, you can do your 3D and you can see the leaflets very well for both replacement.
Okay, great. I think we lost Nadira, but it's a good point to move on. We're going to go on to our next talk, and our next talk is from Edwin Ho, who really needs no introduction. Edwin is a world expert in advanced imaging. He's my partner in my eyes and procedures, and he's also at the cutting edge of a lot of new technologies. Edwin, bring us up to speed on 3D echo and how it's really reshaping what we do in the cath lab.
Sounds great. Thanks so much for the kind introduction. So I'm going to give this next talk about updates this year on 3D ICE. And it's kind of exciting because there actually are some updates to talk about. So we'll head into this right away. These are my disclosures. So I'm just going to do a quick overview of the current generation of 3D ICE catheters, because I think it sort of sets up what our current limitations are, what we're sort of looking for, and what actually these new things, new technologies this year are actually bringing. And then hopefully as a little bit of a preview and maybe discussion point of where we want to see things continue to progress over the next couple of years. So, Nadira already mentioned 3D ICE quite a bit in her talk, and I agree, especially in tricuspid, we use this very routinely now. And of course, the major advantage over traditional 2D ICE was that it gave us all the 3D capabilities that we're used to having with TE. So things like biplane, omniplane, elevation tilt plane, and of course, live 3D and MPR has really been a big game changer. These are the 3 commercially available ICE catheters. They've actually been around now for the last couple of years, but I know that availability and approval in different regions has varied. So we've been lucky in the United States. We've had it for the last couple of years, but they are now doing a gradual rollout through the rest of the world, including Europe and in Asia. I'll go quickly through each one just to have some idea. So the Siemens AcuNav Lumos is currently the more limited 3D probe, just because the number of elements and the type of array it has is a little bit smaller. And so the volume size is more limited compared to what's being offered by Johnson & Johnson Meditech, as well as Philips. So we'll focus a little bit more on that on the current generation. And then again, I'll talk to you a little bit about sort of what we know is here and coming very soon. So this is an example of what the ICE catheter looks like from Philips. So you do see that, it has a rectangular array. It's different than what we're used to with TE, which has actually a square array. And so you have 2 axes on this matrix array, one that's better in terms of your spatial resolution and one that's a little bit worse. And the way I always think about it is 0 degrees is on the long axis of the catheter. That's going to give you the best resolution. And then 90 is at the shortest part of the matrix array. So it'll give you the worst resolution. So the way I like to teach people and tell people about ICE is basically get off the 90. As far away as you can get away from 90 is going to give you the best image quality. And there's different ways to do this. You can do some left-right manipulation. You can do this with 3D, so it's very purposeful. But essentially right now, it does require some physical manipulation to really be getting our best views with ICE. These are just some quick sample images of what the image quality looks like from each of these current generation catheters. So this is the Lumos. So again, it's sort of a 90 by 54 degree maximum volume. Really nice 2D imaging. The 3D is usable, but for sure in that smaller volume that's currently available. The Philips VeriSight Pro for us is our workhorse catheter. It really provides excellent 2D image quality, especially when you optimize those biplane angles. And the 3D, as you can see here, and what Nadira already showed as well with her Evoke case, is actually very usable. So we can use 3D MPR with pretty good spatial and temporal resolution. And that's been especially true since the R11 firmware upgrades on the Epic system. The Johnson & Johnson MedTech New Vision has actually always had some pretty nice 3D image quality and 2D for that matter. It doesn't have the left-right flexion, but these are cases that we actually did a couple of years ago, and you can already see that very usable 3D MPR in particular, both for TEER and for replacement. And then again, I'll show you next sort of how things have improved even further. So when I think about sort of what's new in the ICE world, there's sort of two different parts to it. There's the Echo console, because the probe is going to provide all this raw data towards, some machine for processing. And so even though we don't think it's going to make a big difference, it actually does. So this year, what's sort of new in the Echo world is GE launched the Vivid Pioneer, which is their newest generation Echo console. And because it has a lot better image processing capability as well as algorithms, even though the probes haven't changed, the image quality has. So this is a TEE example, not an ICE example, but this is the pre-existing adult 3D probe from GE. And even though the probe has not changed, you can see this 3D image is really very, very clear. And the MPR basically looks like a 2D image that's acquired just from biplane or even single plane. And so we can already see that base technology of the cart really changes what we actually can get from the probe. So then how does this look with the New Vision ICE probe? I think we are seeing actually some advances in that too. So the image on the left is what the New Vision looks like with the E95. So again, pretty good 3D actually, and usable MPR for sure. But then if you look in the image on the right, those especially MPR planes are looking just so much sharper, so much clearer with really good temporal resolution. And just like with the TE, they almost look like you're taking single plane or biplane images. The 3D rendering that on the top left that you see there is still maybe not as clear as with the TE, but again, the MPR planes to me are really impressive. Same thing in the setting of doing evoke replacement. So again, here you see an example on the E95 and then on the Pioneer. And I think the MPR planes really have taken a sort of jump in image quality, even again, without the catheter changing at all. Just two more pictures that I have from this Evoke case that was actually at OHSU. So they kindly allowed me to use these images just to show you today. But again, I really think it's remarkable what can be done with ICE in this current year. And we're certainly looking forward to doing some cases in the next couple of weeks with this as well. Now, in terms of what's new with catheters, less to talk about, but actually something really exciting in the next slide. First, I'll just talk about this Philips catheter that's actually now commercially available in the US. And again, different geographies, the timing of this is a little bit variable. Essentially, this is not really a new catheter, but it's a new offering from them, which is instead of the VeriSight Pro, there's a single plane steerable or SPS catheter. And it's kind of 3D, kind of not 3D. So, but I still think it's relevant to talk about in this particular session, because essentially it gives us some of the 3D capabilities like omniplane and single plane steering, but it does have the live 3D and biplane actually removed from it. But it does serve as a potentially good cost-effective way to have some of the 3D features depending on what we're actually using it for and what particular cases. And then this is the real exciting part that I sort of was excited to share. So essentially, we are starting to see the first of our second generation 3D ICE catheters, or in Siemens's cases, is actually technically their third generation. So they have a new AcuNav catheter called the Luxera. It actually is not yet FDA approved or approved anywhere else, but we now have first in human imaging from EP cases. And my friend Dr. Debbie Nair lent me these slides and images to share with you, just to show what's sort of coming very soon, and I'm sure other vendors are working on. So the goal here is to be able to image everything, even on the left side, just by staying on the right side. And this catheter is a little bit bigger than the VeriSight and the New Vision, but it has a lot more imaging elements. So over 1700 instead of the 840. Field of view is actually much wider. And then we'll look at some images in the coming slides, and you'll see that they really look pretty remarkable. So if I were to update that table I showed at the beginning, so now, once we have this commercially available, this is going to take a jump ahead of our other 3D ICE catheters, again, just because it has a larger array. And from, just that physics point of view, it actually gives us a lot more to work with and a fewer limitations on that 90-degree angle. So these are live images from a Watchman case that Dr. Nair did. So again, you can actually see in pretty good detail that appendage and that mitral valve, even though we're imaging from the right atrium. And this is certainly sharper than what we have currently available to us. This is what the biplane imaging looks like. And so you can see even on the orthogonal plane off the zero, really looks pretty clear, even though we're using the shorter axis of that catheter. Again, this was a Watchman implant, but you can see the catheter stayed on the right side the entire time. The visualization of the left was actually pretty clear. And then color Doppler works as expected. Our frame rates still stay very nice and high, even though you have good spatial resolution, even with biplane. And then this is just one of the MPR images, which again show that we have good volume rates as well as spatial resolution in this case. So then, what else is coming this year? I don't know if we're going to have commercially available new launches just yet, but I think in the next year or two, we're going to see it. Luxera hopefully will get approval relatively soon, and then maybe we'll be able to actually get our hands on it. And I think we'll see version 2 of Verisight and New Vision soon. So hopefully we'll have those coming, and that will be exciting as well. And then, we use Fusion in our lab all the time. There's some new capabilities that are coming with it, like with Philips Device Guide. So it'll also be interesting to see how these catheters will integrate with those systems in the coming future. So hopefully I was able to just show that we have great commercial options currently already. New consoles and software have already boosted what we can do with the existing catheters. And then we have new catheters that are really on the brink of being available to us. And then other ones that I think are on the horizon, but I don't know what that timeline is, but I'm hoping really soon. Thank you.
That's great. Thank you so much, Edwin. That was a great talk. David, maybe what's your experience with 3D eyes? Is it available in the UK? Is the cost prohibitive, or, have you tried them?
Yeah, no, unfortunately, the cost is prohibitive, certainly at the moment. And we spend all our time wondering, well, if it's going to be actually pretty good, which it's getting pretty good, are we going to be able to put it down the nose? Are we going to be able to put it inside some kind of polyethylene bag so that it never is in contact with the patient? The idea of having it as a throwaway, disposable device when it's capable of so much, and frankly, is going to be very expensive, is pretty hard to square, with often relatively straightforward procedures like, for example, PFO closure. So I think at the moment we're not in the game really in the UK.
Okay. Please don't give people ideas, because I have heard of someone already sticking ice catheters down the nose into the esophagus, and I wouldn't recommend that.
Sounds perfect.
But maybe, yeah, maybe we'll be able to re-sterilize these in the future, and with the company, maybe get a re-sterilized catheter that should reduce costs. But I agree with you. That is the challenge. In the US, it's been great having this available. And I have to say, it's really impacted our clinical practice, which maybe brings me to one of the questions, Edwin, before we move on to the next talk, was from the audience. They asked, how has 3D intracardiac echo changed your approach to structural procedures? In which cases has it replaced TEE in your practice?
Yeah, so that's actually a great question. And I think that's also currently always in evolution. In our current practice, we'll use it for left-sided procedures in cases when TEE is really extremely challenging for some reason, extremely far-field imaging that we can't get around, or if it's truly contraindicated, which has happened to us just a handful of times. It's not common, but it does. And you can do TEER with it successfully, as opposed to being able to offer nothing for the patient. Straightforward mitral valve and valves will also use it for our transeptal and for guidance, and that often can allow us to step away from general anesthesia. Where it's been a big game changer for us is in the tricuspid space, in particular for TEER, because obviously the imaging of the leaflets is a little bit more demanding and more critical in those situations. And what it's really allowed us to do is become very, very efficient with our procedures, because the workflow, as Nadira described, combined with TEE, actually allows you to not really need to move the TEE probe very often, but you get the best of both worlds, and you can move through a procedure very quickly. And I think, compared to in the past when we had very difficult TEE windows and we would tell a patient, this might not be possible for you, I think that's no longer applicable. Same thing for replacement. That doesn't really become a barrier anymore. So I think that's been the biggest clinical change from my point of view, as well as the workflow aspect.
I mean, it's certainly saved some of our procedures, I feel. I think with TIO, we've had better outcomes because we can really see leaflet engagement and then we're grasping leaflets. And I remember a TTVR case where, a commercial case where we opened the anchors of the Evoke and suddenly we now couldn't see anymore because we had so much shadowing from a mitral prosthesis. And now you're committed. You can't. It's not like TIO where you can take the device out if you can't see. With an Evoke, once you start opening anchors, you're committed. You've got to finish the procedure. I've also, just to answer the question, there are colleagues, at Piedmont, Pradeep has done now, I think he said 100 the last time I checked, Evoke cases with only ice and with no TE in patients who are sedated and not under GA. So I think it's a glimpse of, Pradeep always pushes the envelopes. He's very innovative. I think what he's doing is a glimpse of maybe the future where we could do these procedures without GA, maybe under MAC, without, requiring anesthesiologists, which is an important resource in many hospitals, and using ice, especially with the newer catheters you're showing, Edwin, to maybe do more procedures ice only. I think there are real advantages for that for the patient, for workflows in the hospital, and potentially the costs we talk about, David. If you're now taking the anesthesiologist out of the room and you're doing it under MAC, maybe it starts balancing and becomes cost effective.
Yeah, and still, I mean, maybe for 2D eyes, we just about managed to persuade people that it's cost effective not to have the anaesthetist, but our anaesthetists aren't as expensive as yours.
Anyway, let's move on to the last talk, Arif. We leave the best for last. We move away from echo imaging to CT, and tell us how we can use procedural simulations to make us better structuralists and get better outcomes.
Great. Thanks, Azeem, and thank you for the invitation to participate in TIO. Yeah, I think my biggest disclosure would be I'm not an imaging expert. I'm not, in fact, an imager at all. So it was fascinating listening to these talks. But that really, I think, made it interesting for me when thinking about this talk to really answer the first question, which is, well, why do we need advanced CT imaging simulations? Because really the growth of structural heart interventions, not only procedural volume, but also complexity, has been fueled and supported by imaging and, CT planning, TOE guidance. Now we've heard from ICE. So really, I thought I'd focus a little bit on trying to understand what role does CT-based simulation play now in our structural procedures, and really came across with these 4 different domains. So the first thing is its role in pre-procedural planning, whereby you can use these advanced modeling to try to predict how your host device interactions may behave. Sometimes you may have very complex geometrical problems that you're trying to solve, and there advanced 3D imaging can play a role. Then there's this emerging concept of bench testing, whereby you take real patient-specific imaging, convert it into a model, and then you can try to evaluate different things. And then increasingly, as we're moving towards increasing regulation, a lot of device modeling, and that's where simulation can play a role. So I thought I'd just give you a little overview of each of these different domains and how simulation can help us. So to take things very simply, in a way, what we can already do with our CT scans, whereby we take the CT scan, we simulate a valve inside of it, and then we can also simulate a second valve, that in itself is already a form of simulation. Let's say it's a 2D sort of simulation, but we are already doing simulation almost on a day-to-day practice. Even if you don't have software that lets you put a specific valve, just the act of putting particular squares or circles or cylinders, these are all forms of simulation that probably we're all familiar with when it comes to treating valve-in-valve cases, bicuspid cases, and increasingly now this concept of lifetime management and redo TAV. But the technology has progressed. So there is this concept now of the digital twin, which is whereby you take the patient, you use some form of imaging modality, which is often CT scan, to take the patient's anatomy and create a digital twin. And in that digital twin, you basically have the patient's anatomy, and then you can implant your different device or different prosthesis and really then evaluate the host device interactions. So let's look at some specific examples. These are from real cases. So this is a case of a young patient, 72-year-old, who had a small aortic annulus, and generally you can see a sort of a narrow, small effaced aortic sinus. So the question was, we want to implant the TAVI valve, but we want to preserve long-term coronary access because there already is a history of a previous PCI. So how can this digital twin concept help us? Well, these are courtesy of FEOPS, which is one of the brands that can perform these simulations. So what you can do is you take the patient's anatomy, you choose your index valve, you can simulate different implantation depths of that index valve, and then already go in and put a second valve inside. And with all of that in place, in a three-dimensional sense, you can get an understanding of, okay, how will my valvar complex, so both of my valves inside this aortic geometry fit? And what will be my, in this particular case, the question was coronary access, what will my coronary access be? And we can see here that simply altering the depth of your first valve, in addition to the design, you can have a significant impact on the lifetime management and the lifelong coronary access. So this was an example where this digital twin simulation allowed you to already plan your first implantation to optimize the long-term outcome. This is now getting to a slightly more complex scenario. This was a courtesy of a colleague of mine, Joao from Lisbon, who shared this case. It's an 8-year-old lady. She had a degenerated mitral flow prosthesis, so externally mounted leaflets, stenotic degeneration. Here, based on the planning, the concern was risk of coronary obstruction. And of course, we have an established and sort of validated method to evaluate coronary obstruction. But where now CT planning can help us is, this is now using the DASI software, is you can implant different valves where it will behave in terms of how the valve is expected to open, how it will behave with the geometry and also the calcification. So you can run these different simulations, choosing not only different types of valves, but also different sizes of valves, and also place with your implantation depth. And then you can see, okay, maybe with this prosthesis, I might have a higher risk, with this prosthesis, a lower risk. And actually, you can go one step further and actually start to get some, let's call it quantitative analysis of actually what is the risk of our coronary obstruction in this particular case. So with this particular planning algorithm, they've got a formula that they come up with, and if it's higher or lower, and of course, this is based on some studies, but it needs further validation. But the idea is that computer simulation is now not only giving you a visual analysis of how the situation looks, but you can also begin to get some quantitative data and some three-dimensional metrics of the space around and how much risk we might have. And going one step further, of course, one of the solutions then is leaflet modification. So you can also begin to model how leaflet modification might help you in this scenario. So this is whereby an evolute is placed, they've done the bilateral leaflet modification, and you can begin to understand how that splay will look. Could it be effective? Will it be helpful? And then in this procedure, that's exactly what was done. An evolute was implanted with basilica with a successful outcome. Now, that's one example of, let's say, this digital twin concept. Something else that can be done is you can take the pre-CT scan of the patient, segment the aortic root, really create a digital three-dimensional model, which already can give you a lot of information and analysis, but you can also make a one-to-one size replica of the patient's anatomy. And the advantage there is you can take that anatomy, put it inside the cath lab, and then really run these patient-specific bench testing simulations. And this, of course, is a bit more of a, let's say, resource-intensive environment, and maybe it's not specifically for pre-procedural planning, but you can gain a lot of insights from here. So we did a lot of work where tried to look at coronary access and different techniques that could be developed. And because you have the patient's anatomy in front of you, you can experiment again and again with different catheters, different shapes, and just it's a safe environment essentially to practice. And here we were able to develop different techniques, which were then used in vivo experience. Other examples, similarly, this is from a colleague of mine from Germany, Von Kim, looking at coronary access with chimney stenting and developing different styles and approaches to using the chimney stent. Again, he gave me the CT scan. We go and create a bench model, and then we can replicate and come up with these different situations and scenarios. And this was most useful for us. We recently had a case here in Copenhagen, which was a degenerated TAVI prosthesis. The patient was scheduled for a redo TAVI procedure, and we basically had high risk for coronary obstruction to the left-hand side. And it was really interesting process to go from the CT scan, which is how we have an established, validated way to plan these procedures, to come up with a 3D model, which really gives you a sort of a three-dimensional perspective spatially of, okay, what really looks to be the challenge here. And then we took that patient made a specific model and then looked at different leaflet modification techniques and basically simulated the techniques, performed those procedures beforehand before you went into the procedure, also learning what may work or what may not work, what to be careful of. And that ultimately helped us achieve a successful unicorn procedure with a good outcome and no coronary obstruction. So it was really useful, kind of not only from a learning point of view, but also from a procedural planning perspective. And then that's in TAVI, but also across the spectrum of structural heart, this approach is being developed further. This is in left atrial appendage. This is the FEOP software. Again, you can see you can take your patient's anatomy, put different devices of different sizes in different locations, and determine what looks to be the best fit. Now, I think a natural question here is, well, will this help at all? And I think here the PREDICT LA trial, which was a randomized trial, was quite informative. So here they randomized 200 patients, standard planning, which was CT or transesophageal echo, versus using your CT and having a simulation-based plan. And what do they see? So on the procedural efficiency side of things, if you had CT simulation planning, you achieved a much more streamlined workflow. So less devices were used, less repositionings, and which of course then translates into less radiation and contrast. And I think that's not surprising, because you have tried already in your simulation different devices of different sizes in different positions. So you've kind of done a lot of the, let's call it almost procedural learning curve in the simulation, and then you go with one device and it seems to work better. In terms of outcomes, I mean, it wasn't statistically significant, but there was a numerical reduction in leak and or device-related thrombosis, and certainly with single device deployment with complete closure of the left atrial appendage was higher with their simulation planning. And I think this field is going to grow both across coronary and also structural. There are some trials and studies coming now, both from TAVI, left atrial appendage, and also transcatheter mitral valve replacement. So it's a growing field and it's emerging. So it's exciting. And finally, I just end on this slide. So also, I think regulatory bodies are looking at how can we use this concept of digital twins to really try to understand more and more about how these prostheses fit, because there's been an explosion in the number of prostheses that are coming onto the market. So trying to get full 10-year data and then the device evolves is sometimes quite challenging. So here now, digital modeling is also being used to look at different things about how the device sits, how it fits, what's going to happen in terms of shear stresses, modeling, platelet thrombosis, etc. So to end, I would say that procedural simulations can really help advance in terms of planning, of course, but also research and development. This concept of the digital twin, especially when you combine it with artificial intelligence, can really allow you to model different scenarios. Patient-specific bench testing, I think, is a nice bridge between in silico techniques, which is this computer simulation, and then actual in vivo. And of course, we have to wait future studies and trials to see how effective will these be, not only kind of safety and efficacy, eventually, of course, cost effectiveness. Thank you.
Arif, that was fantastic. Thank you so much. And I mean, it's really exciting seeing all the simulation-based software and capabilities that are becoming available. So there's an interesting question from the audience. Unfortunately, we don't have too much time, but I'm going to first have David respond to it, because I always like his comments. They're very balanced. And then maybe you can respond too. So someone asked, what are the current limitations of CT-based procedure simulation? But even more important is, I mean, these images look good. How do you validate the simulation against what actually happens in the lab? And, you know, and how validated are many of these simulations? So maybe, David, any thoughts? Firstly, do you use simulation on a daily basis or for complex cases?
No, we don't. And I was quite persuaded by Oli's work on this, but we don't do it partly because of the purely practical problems of taking patients through CT scanning, in all cases, let's say before left atrial appendage occlusion, and then doing modeling on that, which also incurs greater cost. So the patient has to have more journeys, they have more contrast, more radiation, then they come for a second time. Then the procedure becomes more costly, of course, if we involve 3D modeling. So I think that has to be offset against the way we do the procedures currently. But I accept that, as people are getting better and better at doing predictive modeling. So it's inevitably going to become more and more a routine part of our practice.
Great. Arif, you want to add anything before we wrap up?
Yeah, maybe to take your point about the validation and how the validation is performed. Essentially, they take post-implant CT scans, so whether it's a left atrial appendage or whether it's a TAVI prosthesis, then compare that to how they predicted it should look, and then essentially try to match them closely together. Then I think it's beyond my intelligence, the level of probably maths and mathematical equations and science that goes into it, but then that eventually is used. I think the hope is that machine learning is being utilized more and more. We see in radiology and in other fields of medicine, not just cardiology. So maybe that processing power, hopefully with increasing data sets of imaging being available, both pre and post implantation, should improve the reliability or accuracy of these approaches.
Yeah. I mean, I think that's the part, right? Is I think we need a big database of post procedure CTs, echoes, follow-up to really validate it. Because again, I mean, I understand David's, concerns. This has to work in our workflow of how we treat patients. It has to add something additional. And I can, from what you showed, there's certain like case examples where sometimes I go, I wish I knew what was the right thing to do. I can think of some complex bicuspids, for example, where, because of the anatomy, what's the right valve, what's the right size? But there's also then different variables, right, in the procedure as to how you expand the valve, what valve you use, how many cc's you put in. I mean, I was looking at your basilica one also. I mean, I can't think of a procedure that has more variability in it than basilica, depending on where you pass the leaflet, how you pull, how you lacerate. But I really do think, this is going to be the future. And I think you're right with AI technologies. Hopefully, these simulations can be done in record time so they don't, we in clinic and you can just put it in through a simulator and get the answer, in 10 minutes before you go see the patient, and help us make better decisions. I think we're definitely going to see more of this. But I did want to thank you all. We're running a little late, so I've tried to catch up some time. This was really a great session on imaging, on advances in imaging, really from TEE in tricuspid interventions, which is really the area where interventional imaging is at its peak, to see then how 3D echo is developing and how we're going to have new devices, and then thinking about how we use CT-based simulations in everyday procedures to really improve our outcomes. Thank you all three of you for the talks and for the good discussion, and I hope to see everyone soon. I'm going to pass it on to Nicholas, who is going to take over the next session. Bye, everyone.